All right, so as Nestor already said, it's, the topic is surgical treatment of medically refractory epilepsy in children. And somebody in the audience already said this is, has a signature of Dr. Mathern. So let me just start with the basics. The goal of epilepsy treatment is really no seizures and no side effects. And this is really something that a lot of neurologists and neurosurgeons got together back in 2000 as part of an NIH conference to meet and sort of brainstorm about what exactly is the definition of curing epilepsy. And no seizures, no side effects is the goal that they came up with. And there was actually a subsequent meeting in 2007 to follow up on those goals along with new goals. So I won't get into those, but for the developing brain or the pediatric patients, the goal really is to eliminate seizures as soon as possible to optimize the cognitive development and improve the behavior and quality of life. And this is really something that the ILAE, or the International League Against Epilepsy, got together and developed specifically for kids. And this is just to show you there is actually a lot of developing brains to be saved, just because epilepsy has a bimodal peak. And so predominantly in kids, and then much older later in life in terms of higher age groups. And this seems to be holding up across different countries and across different industrialized countries. So a few more definitions. And these will matter in just a little bit. Idiopathic epilepsy is presumed complex genetic and usually age-dependent epilepsy. It is ideally only epilepsy with no underlying structural brain lesion, and all you're dealing with is epilepsy and no other comorbidities. Symptomatic epilepsy then are epileptic seizures that are the result of an identifiable structural brain lesion, so something that you should be able to see on some kind of neuroimaging. And then cryptogenic then is somewhere in between, whereas epilepsy usually with focal features, both clinical features and EEG characteristics. But unfortunately, the structural problem has not been able to be identified, so it's neuroimaging negative, but focal features. So we think there's an underlying reason for the epilepsy, but we just cannot see it. And so the reasons why these categories matter is that even though cryptogenic makes up the majority of the epilepsies, it is, where's my arrow? There we go. It is not the category that's most intractable. In fact, the symptomatic ones, the symptomatic epilepsies are the ones that are most likely to be intractable, even though it only makes up 19% of the epilepsies. And less of the symptomatic epilepsies are in seizure remission or complete seizure control. And so that's usually the worst off category that we're dealing with. So what happens when you try to treat epilepsy medically? And so this is just to show you the seizure medications in untreated new onset epilepsy patients. And this is a pretty well-known Quan and Brody study that came out in New England Journal of Medicine. So what they found, again, completely new onset epilepsy patients, the first seizure medication can get seizures under control in just about half of the patients, so 47%. By the time you get to the second AED or second anti-epileptic drug, the success rate goes down to 13%, so significant drop already. By the time you get down to the third seizure medication, it's down to 1%. If you try some polytherapy, the success rate is only 3%, and so what you're left with is a little bit more than a third that are not seizure-free.
Does that mean you're adding an additional 80 or you're switching?
Adding. So looking at this, again, new onset, you're dealing with a third of the patients that are not under medical control. And if you look at the timeline of medical intractability, This category is often what we're dealing with in the pediatric neurology clinic. So the youngest of the kids, they tend to be what we call catastrophic, and they remain intractable. They get to intractability fast, and they remain intractable. The focal seizures, however, which may come later in life and more in the adult population, can sort of simmer along and chug along, and sometimes we lose track of how intractable it really is and how many medications we've tried, and so it's something that we need to be diligent about. So it can drag on for years, over decades sometimes. And so when you then look at what happens when you already have treatment-resistant epilepsy and you add on more seizure medications, what are the possibility of success rate? And so this is a combination of many studies of just about 5,000 patients. And we see that when you add on a new drug, only 5% become seizure-free. 35% of them have a more than 50% reduction in seizures. 21% will have actually more seizures versus the 39% with placebo. 8% will exit the trial, and 0 to 2% will actually die during the trial, or just about 1% per year in terms of morbidity. And so this is just to show you that once you become treatment resistant, again, the idea is you can add more medications, but not a whole lot. More seizure control will come about. What happens when you try vagal nerve stimulator then? And these are for kids with treatment-resistant epilepsy again. And again, it's a combination of multiple studies with about 2,000 patients. And again, the seizure-free rate is quite low, only at 4%. A little bit more than half of the patients will have a 50% reduction in seizures. 33% will have a little bit more. 11% will exit the trial, and again, the mortality rate is 1% per year, just like the previous trial. So does it matter when we look at pathology and etiology? Does it matter in terms of seizure control? And so the top line is again mostly new onset cases. And we see that the category that's most likely to be seizure-free are the strokes and the vascular malformations, and hippocampal sclerosis is the group that is least likely to be seizure-free. And again, this is new onset cases, but by the time you get down to hospital referral and mostly to a tertiary hospital like UCLA, almost every rate is less, meaning we are getting more of the treatment-resistant epilepsy patients. And hippocampal sclerosis, in terms of seizure control rate, comes down to 11%, 24% only for the cortical dysplasia.